You're listening to Medscape's In Discussion series on endometrial cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Ursula Matulonis, Chief of the Division of Gynecologic Oncology at the Dana-Farber Cancer Institute and Professor of Medicine at Harvard Medical School. She's the first recipient of the Brock-Wilson Family Chair at the Dana-Farber Cancer Institute. She co-leads the Gynecologic Cancer Program within the Dana-Farber Harvard Cancer Center and an NCI P01 program project grant that is focused on targeting replication stress in high-grade endometrial cancers. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for healthcare professionals.
Hello, I'm Dr. Ursula Matulonis. Welcome to Season 3 of the Medscape In Discussion Endometrial Cancer podcast series. Today, we're going to focus on the epidemiology of endometrial cancer with a discussion on risk factors, how they influence and lead to endometrial cancer, and then how clinicians and patients can use this information. My very special guest today to talk about these topics is Dr. Immaculata de Vivo, who is a professor in the Department of Epidemiology at the Harvard School of Public Health and is also a professor of medicine at Harvard Medical School. She is the co-founder and executive leader of the International Epidemiology of Endometrial Cancer Consortium, or E2C2, since 2005, and is the Melanie Mason Nemec 71 faculty co-director of the sciences at Harvard Radcliffe Institute. Her research focuses on understanding mechanisms of carcinogenesis and risk factors for disease in order to prevent the disease. Dr. de Vivo has studied risk factors for endometrial cancer, and I am really looking forward to discussing some of this research during today's podcast. Immaculata, it's really an honor to have you as a guest on the Medscape In Discussion Endometrial Cancer podcast today.
Thank you, Ursula. If I may, it's a great pleasure to be here.
Oh, that's great. As you know, the incidence of endometrial cancer continues to climb in the United States with worsening survival of patients overall. So ways to prevent this cancer by understanding risk factors is really crucial. I'd like to start with discussion of a manuscript of yours that was published in the Journal of the National Cancer Institute in 2023 that described the development and validation of risk prediction models done within the context of an international consortium. You mentioned in the article that epidemiologic factors alone are sufficient to identify high-risk women for enrollment in prevention or screening trials of endometrial cancer, and that the highest risk patients have a risk of 20% of developing endometrial cancer. Can you talk to us about the risk prediction model, how you developed it, what you found, and how this can be applied clinically and used by clinicians and patients?
Thank you for that question. And just by way of background, and given that a lot of the research that we're going to talk about today comes out of the E2C2, this endometrial cancer consortium came out about in 2005 and 2006. This was an initiative by the National Cancer Institute to sort of bring together lots of studies in different cancer sites as a way of strengthen numbers. And so in this work, it came out of this consortium and where we pulled data across multiple cohorts to develop and validate a risk prediction model for endometrial cancer. In this particular study that you cite, Journal of the National Cancer Institute in 2023, was led by my PhD student at the time, Joy Shi, and it included over 6,000 cases and 9,000 controls to create the model. And the goal was to ask a practical question. Can we identify women at sufficiently elevated risk using information we've already collected, both clinically and epidemiologically? And so we built this model using well-established endometrial cancer risk factors, things like obesity or BMI, reproductive history, hormone use, age at menarche, menopause, and other lifestyle factors. What was striking is that these risk factors alone performed quite well. Now, we had some genetic predictors or molecular markers because I had already published on 3 what we call genome-wide association studies in this consortium. These are methods that identify genetic predictors of endometrial cancer. To be totally transparent, at the time, we didn't have enough to make a difference in the model. And the model itself was able to identify a subgroup of women at meaningfully elevated risk. When we validated this, because you need a validation after you create the model, we found that a subset of women had a projected lifetime risk approaching the 20%, which you mentioned, which is substantial. And if I can underscore that, that's a lifetime absolute risk. So about 1 in 5 chance of developing endometrial cancer by older age. And you compare that to about 1 in 30 in the general population. So that opens the door to identifying women who might benefit from targeted prevention strategies or inclusion in screening or early detection trial. So, how can we use this clinically? Well, I see this as a tool for risk informed prevention. It's not yet something we'd use for population wide screening, but it can help identify higher risk women for lifestyle or hormonal interventions, enrich clinical trials with women most likely to benefit, and potentially guide future screening approaches once we have effective tools. And yes, on generalizability and something that is a next step, we can talk at the end. The one limitation is that most of the underlying cohorts in the consortium, I say were predominantly white because in the last few years, we were able to recruit Black women from sites and universities from the southern part of the United States. And so that's a major gap, especially given the higher mortality burden in Black women. And again, our next steps are focused on that. We want to build and validate models in more diverse cohorts. We want to incorporate social determinants of health and structural factors and explore whether risk profiles and their relative weights differ in different populations. Ultimately, we need models that are both accurate and equitable, and that requires an investment in diverse population data.
That is really quite amazing that that lifetime risk is about 1 in 5 for that high risk group. And, I think that, it'd be interesting to see, as we talk today about the modifiable risk factors of certainly trying to reduce rate potentially through GLP-1 drugs, other medications, and screening efforts they've been harder to come by. Thank you for talking about the prediction models for Black patients and how that you're going to really focus on that, just because we know that that is a population where risk is going up as well as mortality is going up. In addition to all populations, we know that Black patients are shouldering the worsening of survival more than other populations, though other populations are all also getting worse survival too. So I want to talk about young patients with endometrial cancer. We hear about colon cancer, colorectal cancer risk is increasing in younger patients, but the whole story around endometrial cancer seems to be not as much talked about. And, you've done a lot of work on this in another Journal of National Cancer Institute paper in 2025. You studied risk factors for endometrial cancer in younger women. And we know that the incidence of endometrial cancer has increased about 3% per year in women aged 20 to 29 years, as well as in women between 30 and 39 years. So can you talk about this paper, what you found, and also your thoughts about why the incidence of endometrial cancer is increasing in younger women?
Yes, this was an important and somewhat concerning analysis because we did see rising incidence in younger women, particularly those in their 20s and 30s. And in the paper that you mentioned, what we did was we really broke it down into early onset cancer, which is defined as less than 50, and then late onset, which was greater than 50. And in that study, we evaluated risk factors specifically for early onset and found that many of the same risk factors that we know for older women held, but often were more pronounced in the early onset in the younger women. And again, obesity remains a central factor, but we also saw strong associations with menstrual and reproductive factors that reflect prolonged estrogen exposure. And just as, again, this is a disease defined by estrogen unopposed by progestin, right? And any risk factor that will keep a female exposed to estrogen, very early menarche, very late menopause, will give you that risk. So what's particularly notable is that younger women with endometrial cancer have often more severe metabolic dysfunction in early ages. So even though the risk factors held, what we did see was diabetes type 2 much stronger among the early onset. And so why? Well, it's always multifactorial, likely to be many things. The few that I just want to mention is the rising obesity rates at younger ages, early onset and longer duration of metabolic syndrome. I mentioned the diabetes, changes in reproductive patterns, right? Delayed childbearing, fewer pregnancies, and possibly environmental or lifestyle exposures that, we don't yet fully understand. But again, it underscores the importance of prevention earlier in the life course, not just in midlife.
That is really interesting, and I think we're seeing this in clinic where, younger patients. I'm taking care of a 26-year-old with endometrial cancer recently. So this is making an impact. And again, it would just be interesting as we're talking again, the preventative side of things. And this question is really leading after this, what you just talked about, and identification of other endometrial cancer risk factors besides the estrogen exposure, besides the obesity. You've studied hypertension, you've studied sleep deprivation, you've studied intake of omega-3 fatty acids, smoking. Any other risk factors besides what we were talking about already that you think are going to increase the risk of endometrial cancer, but what also might be protective against endometrial cancer?
Obesity is the dominant risk factor, Ursula, but it's not the whole story. One of the themes across my work is that endometrial cancer reflects a broader metabolic and hormonal environment. So, the key factors like obesity and specifically central adiposity, hypertension and metabolic syndrome, chronic inflammation that is always coming through, sleep disruption, in that it may influence hormonal and metabolic pathways, and certain dietary patterns. Okay. And yes, we've looked at smoking. There's a little change in my voice because it's inversely associated with endometrial cancer risk and likely through anti estrogenic effects. But of course, Ursula, it's not a viable preventative strategy given its many harms. And protective factors, yes, I've gotten a couple of publications on physical activity and even physical activity independent of BMI, use of combined oral contraceptives. This imparts long term protective effect. Diets rich in anti inflammatory to counteract the inflammation. Diets rich in anti inflammatory components, including omega 3 fatty acids, and maintaining metabolic health overall. I think the key message is that endometrial cancer is, to a large extent, a metabolically driven cancer, which means there's real opportunity for prevention.
There really is going to have to be a significant change in how people live their lives, especially in the United States. But this is certainly spilling over worldwide as well. Many of us who are clinicians have been, I think, at least I have been surprised by the increased incidence of these high risk histologies. And, when I started my career in practice, the incidence of histologies such as serous endometrial cancers and other high risk histologies were really rare. And one of the explanations for the increasing mortality associated with endometrial cancer is this increasing incidence of more aggressive histologic subtypes, such as endometrial serous carcinoma, as well as carcinosarcoma. And the reasons for this are really unclear. So I'm just curious, do you have any thoughts or explanations for the emergence of these more aggressive histologies, such as endometrial serous cancer? I think that these cancers have been thought not necessarily related to this kind of estrogen exposure, but perhaps they are. And I would just love to hear your thoughts.
Yes, I started studying this disease in 1998, and it's something many of us have noticed clinically and epidemiologically. The increase in high risk histologies is likely contributing to the rising mortality despite the improvements in care. And again, it's likely to be a combination of factors. And here are a few that we've thought about: population aging. So, aggressive subtypes are more common in older women, and there's shifts in risk factor profiles. Obesity may be contributing indirectly. Although these subtypes are considered less estrogen driven, in a paper that came out of our consortium, we found that the risk factors are also pretty similar. The magnitude of effect is a little less in these aggressive types. Improved classification, so with better pathology and molecular characterization, we're identifying these subtypes more accurately. And underlying biology, there may be distinct etiologic pathways that we don't fully understand. And again, this is an area of active research that we can talk about at the end.
Yeah, thank you so much. I'm getting to ask you all of the really perplexing questions that a lot of us are asking. So this is great to hear your answers. You've also studied the trends explaining the rising endometrial cancer incidence by many different factors: age, race, and ethnicity, which was published in JNCI Cancer Spectrum in 2023. And what did you find in this paper? And why do you think that Black patients do have a higher mortality than white patients when diagnosed with this cancer?
Well, in that work, we examined incidence, yes, trends across demographic groups and found that rates are increasing across nearly all populations, but not equally. Black women have higher mortality, higher incidence of aggressive subtypes, worse survival, even after accounting for stage. Why this disparity? Again, likely to be multifactorial, but the hypotheses are differences in tumor biology, greater proportion of aggressive histologies, structural inequalities in access to care, delays in diagnosis and treatment, comorbidities, and underrepresentation in research. This is an underserved, understudied cancer, and more so in Black women. So there's no single factor, right? It's the intersection of biology and systemic inequities. And addressing this requires both scientific and public health approaches.
Yeah. The points you make are hugely important. And as we all work together moving forward, really to tackle this cancer, I think you've brought up so many really important issues. As I have researched your writings, I discovered that you have written a book called The Biology of Kindness: Six Daily Choices for Health, Well-Being, and Longevity. I mean, I think that this book is especially important for our current state of the world. And can you tell us about this book, talk about the six daily choices, and what motivated you to write this book?
I'm smiling because when I saw this question, I said, wow, Ursula really went deep. This book came out of COVID. This came out of a meeting in 2019 where I presented some work on the biology of prosocial behaviors. It was originally written in Italian and then it got published in Spanish and now it's in English. But the book was really inspired by thinking about how everyday behaviors influence biology in measurable ways. And so my work in studying aging and using objective measures like epigenetic measurements, in particular telomeres, which are considered a biological marker of aging, I was able to be part of many research studies where we were able to assess these prosocial behaviors. And sure enough, they were measurably different between those who practiced and those who didn't. So, as an epidemiologist, I study how exposures affect disease risk. And I realize that many of the most powerful exposures are something we do daily. And so the six choices you ask are physical activity, nutrition, sleep, stress management, social connection, and, by extension, kindness, and purpose and well being. And what motivated me was the idea that these behaviors just don't feel good. They influence inflammation, immune function, and metabolic health, and are directly relevant to diseases like the cancer that we study. It's really about translating science into actionable daily practices. And I think it's become so popular. There was a podcast done by the Radcliffe Institute that is now a freshman year seminar. And I couldn't be more thrilled. Thank you for asking about that.
Well, congratulations. That is pretty fantastic that it's now a freshman class. I really want to talk about what research projects you're focused on now. I mean, your breadth and body of work is extremely impressive, but what are you focused on now and what's ahead?
Thank you for asking me. I'm very excited to talk about the current and future research that will come out of this. It's focused on my current UO1 that I have in the consortium, where we have over 10 studies, mostly from the southern part of the US, Louisiana, Alabama, North Carolina. And the reason the geographical sites are important is because the focus is trying to understand this disparity that we keep referring to. So the idea is to integrating data from diverse populations, but not just epidemiological, clinical, but also molecular data to better understand risk and prevention. So the main focus is the tumor biology. It's essentially we're doing whole genome sequencing and whole exome sequencing to define the tumors. And then we're going to use all the harmonized data across 40 studies, oodles and oodles of cases. More importantly, a large representation, and I don't want to use hyperbole, but we were told the largest population of Black women to be sequenced that will enter the database. And we're going to refine and expand risk prediction models, especially in diverse populations. We're going to look at early life and life course exposures. We're going to understand the role of metabolism and inflammation, identify modifiable risks that can be translated into prevention strategies. And we're also increasingly interested in how to implement these findings, always moving from discovery to impact. And I'm particularly excited about the potential to really understand this disparity. And this is our time, given that right now the samples are being sequenced at CIDR, which is a Johns Hopkins sequencing facility. All the data has been harmonized at the Memorial Sloan Kettering portal, which has always been the site of where the data has been stored and collected and harmonized. Our Harvard part always served as the lab part, the home base, so to speak. I really just want to highlight that endometrial cancer is one of the cancers that we have a real opportunity, Ursula, to intervene because many of the risk factors are modifiable. And the challenge now is figuring out how to implement that knowledge effectively and, more importantly, equitably.
That's really extremely impressive. And thank you for really detailing the future goals. And I mean, I think the research that you're doing, have planned, it's incredibly important. So congratulations. Anything else that you'd like to talk about before we end today?
Well, I'm particularly excited about the potential for this precision prevention using risk models, biomarkers, and lifestyle data to really tailor prevention strategies. A lot of the epidemiological studies that we do is based on population level data, which is terrific. And so sort of bring all that together to do more precise precision prevention. Because, one of the things that attracted me to this cancer, like I said, in 1998, is that it had exquisite risk factors. Like you could really understand the risk factors, which was even at that time pretty remarkable because many other cancers, the risk factors were not so clearly defined, and this is something we can actually make an attempt to lower the risk.
Thank you so much for this really rich discussion today. Thank you so much for your dedication and what you do, and so much of your research that is focused on endometrial cancer and preventing this cancer and really getting the incidence to turn down and to improve overall survival. So today we've talked to Dr. Immaculata de Vivo about the epidemiology of endometrial cancer. We talked about risk factors, which risk factors she's studied, which are many of them and most of them, how they influence and lead to endometrial cancer, what research Dr. de Vivo has planned for endometrial cancer, which is quite impressive, and also her really neat book, which is really super cool. So thank you so much for tuning in. Please take a moment to download the Medscape app to listen to and subscribe to this podcast series on endometrial cancer. This is Dr. Ursula Matulonis for the Medscape In Discussion Endometrial Cancer podcast.
Thanks for listening to Medscape's In Discussion Endometrial Cancer podcast series with our host, Dr. Ursula Matulonis. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on endometrial cancer.